Thanks, Hunter. It's a very nice introduction. All those directorships he talked about, it was just because I was gullible enough to take them up. That's basically about it. So I want to talk to you today about something that is going to be a very, very hot topic coming up. And it's lung cancer screening. A lot of controversy still related around it. Any of you guys that know me know that lung cancer is my passion. I'm a firm believer that we are going to make a huge dent in lung cancer care here in Eastern North Carolina. And our goal is not only to be the premier place for lung cancer therapy and research in Eastern North Carolina, but North Carolina, and I'd even like to say the country. I feel very strongly that we've got the tools here to do that. And it's just going to take some guts and some hard work to get it done. And this is going to be an integral part of it. It's going to be lung cancer screening. So I'm going to go over some data today. I'm really not going to try to bore you a whole lot. You guys are scientists and you want to see data, and I'm going to give you some data. But I primarily want to focus on where we think it's going to move to and then some of the socioeconomic factors associated with it. I am a paid consultant for Covidien Surgical Solutions. They don't really have anything to do with this talk. For those who don't know, Covidien actually makes the electronic navigational bronchoscopy device, which is something I'm integrally involved in, but I get no money from them for speaking on subjects like this or anything. The objectives here, I know you guys are familiar with. You can review those. We'll explore the evidence in support of lung cancer screening, review the methods used for lung cancer screening, discuss who should be screened for lung cancer, as well as some of the economic effects of it. Just some background stuff. You know that lung cancer is the leading cause of cancer death. The American Cancer Society predicted about 200,000 new cases and 160,000 deaths in the U.S. In last year. Kills more people than colon, breast, and prostate combined, which always really gets me when I think about it. All those cancers combined, lung cancer is killing more folks. And I know you guys have drove around Eastern North Carolina, and you've seen the tobacco fields, and you've seen the patients. And recently the CDC made an announcement that said the lung cancer is declining. They haven't been to Eastern North Carolina. In our world, it's not. So approach to a patient with lung cancer in general, you got to diagnose it, you got to know what it is. You got to figure out how far has it traveled, what's the stage. I'm going to speak very briefly at the end of this about what stage means and exactly where lung cancer therapy is going. And in general, the further the stage, the worse the prognosis. But I'm going to try to beat into every person that I meet that stage doesn't matter much anymore. I've seen people with stage 4 lung cancer here in mets to the brain live much longer than they are expected to live. Therapy's changing. We're on the cusp of making a difference. You put those two things together, you've got to get a biopsy to figure out, or some kind of tissue to figure out what it is. And then all that's going to tell you how you're going to treat it. So any kind of screening test, we know that prevention is the best way to go. And it's going to be the most cost-effective, no doubt about it. And we know that probably 90%, more than 90% of lung cancer is related to smoking, but not all of it. And we're starting to see younger people, and particularly women, show up that are non-smokers that are developing lung cancer. And that's one of the failures, I think, in lung cancer screening. We'll talk about it. But the best strategy is really to prevent it. We know that less smoking is less lung cancer in men in the U.S., and the rates are still about 24%, and secondhand smoke is just as deadly. 30% excess risk if your spouse smokes, and women are at higher risk. And I can tell you, as someone that does this every day, I'm starting to see a lot of women that are coming in, younger women, and I can't figure out if I'm just getting older or if lung cancer is getting younger. But when you start seeing people come in that are right around 3 or 4 or 5 years of your age and have these cancers that when I was sitting out here where you guys are thinking, oh, I don't have to worry about that, it really starts making you think. And I'd like to think I'm still relatively young. I'm in my 40s now, and I'm starting to see a good number. And I'd probably say in a month, I'm probably seeing 5, 6, 7, maybe 8 patients in their 40s that have lung cancer. Lung cancer, not breast, lung cancer. So the concept about screening, just to kind of go over this, is you want early detection and treatment, prevention or survival in asymptomatic patients. So that's really what we're trying to do. And it assumes, and we all know what we say about assumptions, but by getting a screening test, it assumes that the disease is in a treatable phase and that if not treated, it'll progress. And this has always been quite a bit of controversy about screening. You know, if you catch it, can you treat it? Is it going to make a difference? And if you didn't do anything about it, does it progress? Or will our immune systems take care of it? We never know about it. How many of us could walk around at any time with little bitty cancers that are popping up here and there, but our immune system gets rid of them? We don't know. And that's what the theory about screening does. Is early treatment better than late treatment? So the best test for screening is going to be a high sensitivity, again, true positives for early detection, high specificity, true negatives. It doesn't cost very much. And then we want to reduce mortality and improve quality of life. So what's a good screening test for lung cancer? Well, lung cancer is good to screen. Why? Because it can increase overall cure rate. I'll show you a little bit of data about that when we catch folks who have it early. We want to increase limited surgical resection, and what we mean by that is be able to catch these patients with very early cancer that we can cut out. Because we know that right now the only really true cure, and this is a little bit of a statement I have to be careful about, the best cure, I guess I would say, is going to be surgical resection. We can decrease morbidity and mortality. And again, this assumes that all lung cancer progresses. And there's controversy from some of the screening studies that does early stage lung cancer identified by screening are not precursors or advanced or incurable disease. Still not sure. We know that if you get no treatment in non-small cell lung cancer, and this is a study that came out, let's see, what's the pointer? This little thing here?
Up on the backside.
Gotcha, sorry. I didn't want to hit something and let it explode. All right. So if you don't treat early stage lung cancer, and you guys think about how many times you get a CT scan and you see a pulmonary nodule somewhere. You don't treat early stage lung cancer. This is from a guy named Detterbeck, who's a pretty big name. He used to be right up down the road there at that place that's Carolina Blue. And then he moved on over to Brigham's. He's a fairly known thoracic surgeon. But he did a study along with Gibson, as well as a very recent study that came out, Systemic Reviews, that basically said if you don't treat stage 1 lung cancer, 1 and 2, 98% 5-year mortality, 98% of people are dead in 5 years if you don't treat it. I got a question last time I was here. Dr. Majors, my boss, says, well, Mark, what do you do with all these little nodules? Why don't you just leave them alone? Well, we don't know, but if they're high risk and they turn into cancer, 98% of folks are dead. Whereas I'm going to show you in a minute that the majority of those folks could have been cured. The median survival is 10 months if you don't treat non-small cell lung cancer. This is the staging system that we talk about, clinical stage and pathologic stage, and then you've got your numbers here. As you guys know, the more advanced you are, the worse the prognosis overall. Again, I want to say that that's a tool that we use, and the one thing I always say this when I'm talking to folks is that remember what statistics are. Statistics are taking a whole huge group of folks. It's important, but there's always an individual. And the individual can always defy the statistics. But statistically, at least from what we know right now, you can see that when you're in the early stages, you have a much better chance for survival. And particularly with these early stage lung cancers with surgery, you have a much better 5-year survival rate. So size matters in stage 1 lung cancers, particularly non-small cell. If it's less than 2 centimeters, the tumors greater than 2 centimeters are more likely to have nodal metastases. And it's just like anything else. It's all kind of about real estate. If that nodule, that cancer has traveled, then more likely you're going to have a worse prognosis, at least right now, we think. So the bigger the tumor size, the more likely it has it's metastatic. So early detection at a smaller size perhaps means longer survival. So lung cancer characteristics, what's affected? Am I going backwards or forwards here? Okay, sorry about that. So potential harms of screenings, abnormalities that require further test. Majority of the studies I'll show you in a minute have actually had false positive rates, which means they found a lot of nodules in there that weren't anything. So you're going to get a lot of false positives. That may lead to procedures. Now, I'm sitting here, I'm a procedural guy. That's what I do. So I'm sitting here kind of rubbing my hands, okay, but just remember the complications that come from that and the costs that come from it. Radiation from imaging, anxiety from prolonged follow-up, and then overdiagnosis. So some of the studies now that have really first came out, I'm going to go through a little bit of the history of it, just kind of give you a synopsis, is it really started with chest x-ray screening. And there's been really 7, but 4 large controlled clinical trials. No randomized trials had demonstrated mortality benefit, and that's what I want to show you here. And the screening, I'll show you a chart in a minute that's got all the studies listed out. Most of the screenings did chest x-ray with sputum cytology at different rates and at different times. Why did they use sputum cytology? Where's one of my students here? Who's a student? You're a student, right? What's the most common lung cancer out there? What's the most common type of lung cancer? Tell me. Good try. Almost. Anybody else know? Starts with adenocarcinoma. Good. Does anybody know about the characteristics of adenocarcinoma? Where's a resident? I'm going to find a good resident. Somebody give me a resident. You're a resident. Tell me, what's the characteristics of adenocarcinoma? Do you know? Is it central? Is it peripheral? Is it... It's actually peripheral, but that's a good try. That's okay. And the reason why I'm bringing that out is because when these studies were done back in the 70s and 80s, the most common cancer is actually squamous cell. And what do you think squamous cell is? If adeno is peripheral, squamous cell is probably central. And if it's central, then that's where the sputum cytology kind of comes up. So that kind of skewed a little bit of these studies here. Now most of the common is peripheral, which is adeno.
So why the change?
We think it has something to do related to the smoking because adeno is certainly turned on more by smoking. And with the smoke going up to the way the smoke is distributed in the lungs, there's a lot of these peripheral lesions. That's what we think. But when these early studies were designed, that's why. And that's why they used the sputum cytology and chest X-ray. But again, no mortality benefit, but they did detect cancer. They found out you had early cancer, but it didn't make a difference. And they didn't really have, except for one study I'll mention, which is a little bit later, looked at screening to no screening. There's always screening to less intense screening. And that was one of the other criticisms. So these are some of the big studies here that really came out. The Sloan Kettering was a real big one, and Johns Hopkins. And you can see this 5-year survival rates. And they detected more cancers, but they really didn't show any mortality benefit at all. But one that is still fairly common, I know you guys have heard about this, is the PLCO study, and that was one of the more recent ones. And the PLCO study was a very huge study that looked at overall different screening modalities that are some of the more common cancers, so prostate, lung, colorectal, and ovarian. And it's an interesting study if you read it, and this had a huge impact on the CT scan study that I'm getting ready to go over now. But it still showed to lung cancer, no mortality difference. But you did diagnose more cancers. Actually, it diagnosed more cancers in all of these screening tests, but from my understanding and interpretation of reading it, the only one that really came out that showed a mortality difference was the colorectal screen. The cervical and everything else really didn't at all. And in this particular study, what they did for the lung is they did chest x-rays. Again, just chest x-rays. But the interesting thing about this study is that they did compare it to no screening. And they called it communal care, which really meant standard care. So they had you screening chest x-ray or prostate or whatever it was to the usual care. And this is going to be important in a minute because the national trial that I'm getting ready to show you for CT screening actually used this data, some of this data. So screening with chest CT, the development, basically because there was a lack of mortality benefit with chest x-ray, and CT scanners have really gotten good. I just got a consult yesterday in the clinic from a guy who they keep finding these very small, super duper small subsegmental PEs. And everything else is asymptomatic, and I don't know what to do with them. But subsegmental PEs, I mean, you can find these things. The CT scanners are so good. I don't know what to do with them. And that's what I mean is they've gotten so much better and things are getting so much thinner and we're picking up all this stuff. And I think when this stuff started development, we started saying, hey, we can do these CT scans. We can do really thin slices, and we even can use low-dose radiation now and do them very quickly. And that's how this kind of came about. With all the background of what I'm telling you of trying to detect lung cancer early. This chest x-ray didn't seem to cut it. So there's been 6 trials, single center, single arm. The detection rate has gone anywhere from 5% to 51%, so pretty wide range of this. Very high false positive rate, and there's been no mortality data to date. Now, a lot of these trials just stopped around 2000, 2001, kind of started maybe in the late 80s. And you can kind of see the charts here. So a lot of this data is still accumulating as far as mortality data. So the National Lung Cancer Screening Trials, NIH-sponsored trial, basically said, well, they saw this stuff and said, let's do a feasibility study. Something's shaking out here. And when they designed this particular trial, the PLCO trial was also going on. And what they decided to do was, first of all, do a randomized, hadn't been done, multi-center, 33 in the U.S., hadn't been done. Now, the PLCO trial was multi-center. And they actually used a lot of the PLCO sites for this. And they said, well, let's do low-dose CT scanning versus chest x-ray times 3 years. Why chest x-ray? There's still no standard of care. We just got through saying that chest x-ray detected more cancers, but it didn't improve mortality. Well, they anticipated when this was being designed, the PLCO was going on. And they said, well, we think that probably something's going to come out of this with chest x-ray, so that's probably going to become standard of care. So that's why the chest x-ray was used. They wound up being wrong, but that's why they used it. They went back later on, and I'll explain what they did when they actually looked at cost effectiveness and some other things. So they decided to do this. You got a chest x-ray or a CT scan once a year for 3 years if you're a high-risk person. And the high-risk person where there was 53,000 men and women, you had to be the ages 55 to 74, 30-pack year smoking history, and you had to stop smoking in the last 15 years. And they had a follow-up at 6.5 years. So not a super long study. So you got either CT scan or chest x-ray once a year. Did that 3 years, they had a follow-up of 6.5 years. And they tried to detect, did the folks die, did they not die, how many cancer developed, what happened. This is just an overview of how it was designed. So person at risk, healthy or former smokers, they screened them with either chest x-ray or helical CT. So they wanted to follow all their adverse effects of screening. So they wanted to look at early lung cancer detection or their adverse effects of treatment once they found it. What are the immediate outcomes when they found it? Surgery for cure, decreased late-stage disease, so they wanted to record that. And then they also wanted to look at health outcomes and other outcomes. And the health outcomes are what was the mortality, which is the biggest one, over all mortality, all-cause mortality. Not did the person just die from cancer, but did they die from other things too. And then what was the quality of life of the person? After we went in and resected their lung, or we radiated them, or we did all these things, what would happen? And then they also wanted to look at healthcare utilization and cost effectiveness. How many times do you turn on the TV, pick up a magazine, or anything else these days? That's the biggest thing, right? We're in the age of the Affordable Care Act, and lots of changes going on in healthcare. This is a huge, huge topic. And the Affordable Care Act, I'll tell you right now, drastically affects this. I think in a good way, actually. So the incidence here is CT scans that is 645 cases in 1,000 person years. That's about 1,060 cancers. And remember, these were actual nodules that they found, so one person could have more than one. 247 deaths per 100,000 person years. Chest x-ray was 572 out of 100,000, 309 deaths. And the incidence rate ratio was 1 to 1.3. The bottom line is this, and notice I bolded it. If you use low-dose CT in the high-risk population, with what I just mentioned to you, 20% reduction in lung cancer mortality. I should say lung cancer mortality there, sorry. 20% reduction in lung cancer mortality. It's pretty big. 6.7% reduction in all-cause mortality. So not only did low-dose CT screening help just your lung cancer screening, but your overall mortality too. Does anybody have an idea of how that happened?
Started going to doctors.
Started going, that's good thought. Started going to doctors. What else do you think? This is a statistical thing.
Coronary calcium.
Coronary calcium, okay. You know what they do? If I take out the lung cancer out of that, it equals out to everything else. So this number's a little bit of a statistical farce, I think. You gotta be a little careful with it. Because when they say 6.7, if you take that out, the majority of those are lung cancer folks. That's one thing you got to be careful about reading this. So to me, the biggest thing is the 20% reduction in mortality more than anything else. So false positives. This is a big controversy, one of the big controversies. Obviously, I'm introducing several here about lung cancer screening is that you're going to pick up all these nodules. What do you do with them? False positives pretty high, 96% for CT and 94% for chest x-ray. The complication rate was 1.4% for CT and 1.6% for chest x-ray. The thing I want to tell you though is most of these were determined as being false positive, non-invasive. Non-invasive. So I know you guys have had pulmonary nodules in your clinic, and what do? You look to see, okay, what's the size? Are they high risk or low risk? And then you decide we're going to follow them for so many months, based mostly on the Fleshner criteria, whatever criteria you use, and then see if they get bigger. And that's exactly what happened here, that most of these false positives were determined by radiographic methods only, and not by going in and invasively boxing. But when they did, there was a small complication rate. The rate of detected cancer did not decrease between screening, which is really important, which means that they did catch these cancers with CT early, which is what they wanted to do, but they had more late-stage cancers in chest X-ray, which would make sense. Small cell was less than 10% detected cancers, and the most common, adenocarcinoma, right? You'll never forget that one, will you? Okay, do these findings relate to all? And that's one of the things you have to do when we look at a study, because we all know how these studies are, right? These studies go to big, huge institutions that are very powerful and have all these super duper duper experts there. And they can do all these things. They have people with extra special training to read these extra special CTs and all this kind of stuff. And do they relate to the doc down the street or the community doc down the street? And there might even be an argument, should the community doc down the street be doing them? I think they should, as long as there's a system in place, and we can talk about that in a minute. But the participants were higher educated and younger tobacco users than most of the U.S. Census data, again, were the patients we were screening really who are patients. And there was low there were low complications, and that was probably because of the expertise in the centers. If you have a center that does a lot of transthoracic needle aspiration, and you have a center that does one every 3 or 4 months, who's going to have the most complications? Probably the people who don't do them as much, because they're just not as experienced. So you always got to take that into account. And then radiology performance may not represent community-based practices. Again, we happen to have a couple of radiologists here who have done extra training, special training, as super fellowship in just thoracic radiology. So that's what they do. That's all they do. So they might have a little bit different take on these things than someone who hasn't had that extra training. So CT screening reduced mortality in high-risk populations versus CXRx and usual care. Now this is the inference from the PLCO data. And I told you the PLCO, what they did is they compared that to what they call communal care. So after the study, the investigators went back and tried to say, well, what if we did it, just with usual care? And they actually found out that it did prevent lung cancer. And they said the number needed to screen to prevent one cancer death was about 320. And then the cost of screening per life saved, and this is kind of the controversial part, and I don't think this question's been answered. And I'm not the best economist. I get a little bit, I have to admit, when I read these studies, I really get lost in a lot of these ratios and the numbers that they talk about. And it's kind of tough for me, and then every time you see a positive paper, you'll see a negative paper. And I don't really know if we know what's going to happen in the end. We're just going to have to see. There was a high false positive rate, which means more tests. So it's not just screening. So when you screen these folks, if their CT is completely normal, see in a year. But if their CT is not normal, then you're going to have to do something about it. So that might lead to more CT scans. Or it might lead to going to get procedures. And that's okay if that's what needs to be done, but we have a whole clinic I'll tell you about over at ECHI where all we do is follow pulmonary nodules. So I have patients come in every 3, 6, 9, 12 months and get a CT scan. I'll tell you right now, in my experience, the majority of those patients, it's not cancer. It never grows. And at the end of 2 years after doing that, I say, see you. So let's look at the evidence. Chest X-ray and CT detect early stage asymptomatic lung cancer. That's been shown. It does detect it. CT is more sensitive to identifying small asymptomatic lung cancer, and chest X-ray does not reduce mortality from lung cancer screening. Both have high false positive rates and more imaging and procedures. But the NLCST basically said that 20% reduction in mortality, the 6.7% all-cause mortality, again, I relate that, and I think most of the criticism in this paper agrees that it's from the lung cancer. Cost effectiveness and high false positive. I'm going to talk about the cost effectiveness in a minute. And then low procedural complication. Is that an average center? So in other words, is this ready to go prime time? Are we ready to say that based on this study that we should change everything we do, insurance companies should pay for lung cancer screening, and we should get it? Well, yes. The U.S. Preventative Task Force, which is pretty much it, has now come out and said, this is December, and I hope you guys, I always have told never to apologize in a lecture, but I must in this one because I'm worried this is too small, but I actually cut and pasted this right out of Annals Internal. But they came up and actually made a statement, and they are giving it a grade B for this recommendation. Asymptomatic adults aged 55 to 80 years. Notice that's different from the trial that I just showed you. Why? Because everybody's got their own take on this. And I'll show you. Thoracic surgeons have different guidelines. The oncologists have a little bit different guidelines. So they kind of encompass it. I actually like that age. So 55 to 80, 30-pack year smoking history, and currently smoke or have quit smoking within the past 15 years. So that's very similar to what the NLCST just did. This is what got me to the recommendation. Screen annually lung cancer with low-dose CT tomography. Discontinue screening when the patient has not smoked for 15 years. I was kind of floored with that. So you just continue going. I mean, that was pretty good. It's a grade B. So this is the U.S. Preventative Task Force, and as you guys know, once this comes out, this affects a lot of insurance companies. And I'll show you in a minute with the Affordable Care Act, it directly affects them. Directly, because it's in the Affordable Care Act to pay for screening services that have a grade A or B by the U.S. Preventative Task Force. So here's the National Comprehensive Cancer Network's guidelines, and they were actually the first to come out with it before anyone else, so I give them credit. And they pretty much went just along with what the NLST did. Age 55 to 74 years, graded 30-pack year history, current former smoker within 15 years. They said if initial scan is negative, annual screening recommended until 74 years of age. Have relations with a center that have the capabilities of management of indeterminate lung lesions. And this is, again, they went a little step further to say that you've got to have a system set up. And then these are all the organizations that endorse it. And you guys are probably familiar with a lot of these. American College of Chest Physicians. So the cost. This is a very recent study that just came out. This is from a group that looked at not only the cost effectiveness of lung cancer screening, but what if you add tobacco cessation to it? And the way it looked at this, first of all, notice it says hypothetical. So this is like a hypothetical model, and it's one of those economic models that they come up with. And what they said is, okay, this is looking at the cost of not only the consumer who has insurance, is paying into insurance, but also from the insurance company. And what they basically said is they took a hypothetical cohort of 18 million high-risk individuals. They were adults over 15 years, and they added low-dose CT screening to it compared to no screening, same risk factor, to no screening. The expected cost of screening per member paying insurance was 76 cents per month. It saved 1 million quality adjusted life years. Insurers' costs were $27.8 billion in 15 years. The cost utility ratio is 28,000. If you added smoking cessation to this program, it increased the cost, but overall it lowered the quality adjusted life years from 16,000 to 23,000. And they found that this number is very similar to what they found in breast, colon, and cervical. And again, it's a hypothetical. Another study came out about the impact on the national budget, and this is from the Journal of Comprehensive Cancer Network. And they said low-dose CT screening added 1.3 to 2 billion in annual national expenditures if your uptake rate for 50 to 75%. It'll avoid 8,000 premature lung cancer deaths at 75% uptake. The additional cost of screening to avoid one cancer death is about 240,000. So they said that you got to take this into account before we actually implement it. The Affordable Care Act and screening. Healthcare plans are required to be covered. Any screening given an A or B recommendation by the U.S. Preventative Task Force. That is in the Affordable Care Act. It is law now. No deductibles, no co-payments. This includes Medicare and Medicaid. So part of this, when you set up a lung cancer program, and I'm still not real clear, I don't think any of us are clear exactly where it's going to fall now, and what the insurance companies are going to ask, or what they're totally going to provide. Just the cost of CT scanning, tobacco cessation. Are they going to demand that it has to be a center with a program set up that follows what happens with the patient? But right now, certainly, there has to be smoking cessation along with it. I believe that. And in that particular first study that I showed you that looked at the hypothetical, they said that if you add a smoking cessation program, that it improves effective screening by 20 to 45%. the patient has to have an ongoing commitment to screening. So anybody who wants to be screened should meet all these criteria. They should go through smoking cessation, that should be offered. There should be an ongoing commitment. And then they need to understand what happens if you get a positive test. If you see a nodule, what's going to happen? And are they willing to undergo surgery or procedures or those kind of things? Because that's what can lead to this, is more studies and more procedures. Word about PET scan. When I first came here out of my last job, I was kind of so-so on PET scanning. And with our programmatic approach here for our treatment of lung cancer, PET scanning is extremely important. And I've grown to really understand the utility of it, particularly with this. But there's been 2 studies that showed that CT screening with detection of a greater than a 7 mm non-calcified pulmonary nodule followed by a PET scan. And you can see the sensitivity and specificity over here for diagnostic of malignancy. The big thing is if it's a negative PET scan followed by a CT scan 3 months later, it's 100% negative predictive value. So if you get a pulmonary nodule in a high-risk patient that you're concerned about, it's greater than 7 millimeters. You get a PET scan, if that thing is negative, and you get a CT afterwards, you know. Is this going to be put into the guidelines? I don't know. Other technologies are out there and are coming. This is an age where we are actually looking at different cancers and the genetics of the cancers and how we're going to take those therapies and put them to those different types of genetics of cancers. So immunostaining, molecular analysis of sputum markers, automated imaging. I mean, there's fluorescence bronchoscopy, which I'm going to go ahead on the record and say I think it's useless, but it's out there. XL breath analysis, genomic and proteomic analysis of bronchoscopic samples. I do think that's going to be a growth. And then serum protein stuff, that's out there too. And this is just around the corner, and maybe you won't have to do CT scanning. Maybe a combination of CT scanning and a blood test, or a breath test, or even a dog, who knows, right? We got these cancer-sniffing dogs. So in summary, lung cancer is the leading cause of cancer death. Prevention, questionably has a greater impact on mortality than screening. And I got a question mark there, because I guess I'm a little bit cynical, but I do think that it's going to make a difference. It makes common sense to me. So the passionate individual person in me says, I think it is going to work and it's going to make a difference. But the scientific part of me says, well, wait a minute, are we really sure? Because we know, we've got one study out there. It's a good study, but are we really sure? And I think time's going to tell. We need to implement this thing and see what happens. Detection of early stage lung cancer, limited treatment and higher cure rates. And this chest X-ray and sputum does not reduce mortality. So, large studies suggest that CT screening may reduce lung cancer mortality. Patients that smoke should stop. A comprehensive approach is important. And this is going to be my final remarks. I'm going to spend just a couple of minutes on it. I think that we're in an era now in lung cancer treatment that, and probably in healthcare in general, we're seeing that multidisciplinary approaches are really going to be best and are going to be the most effective. I think, particularly for conditions like lung cancer. And I think when you implement something like lung cancer screening, it really needs to be in a process like this. And this is what we intend to do here fairly soon, so stay tuned. It's through our multidisciplinary thoracic program, we'll have screening, diagnosis, staging, and treatment. And in order to do that, you've got to have the framework and the system set up. I'm telling you, we have it already here in Eastern North Carolina. We have the network of the Vidant Health Systems. We've got the School of Medicine as the hub here. We've got this stuff set up to where we really can make an impact on lung cancer. I'm very passionate about what I do. You guys are scientists, and I want to show you evidence. And I don't have it yet, but I will someday. And I'm telling you from my gut, we are making a difference with this approach. When we see these patients and we do it in a multidisciplinary fashion and we do it as fast as we do and as effective as we do, I'm telling you, the outcomes I feel are going to be different, but I can tell you right now as I stand here, the effectiveness of this approach is definitely. You guys call us with a lung nodule or a lung mass, we will have them assessed, diagnosed, staged, and starting treatment within 2 weeks. Go see if you can get that anywhere else. I'm living it. I'm telling you that's the truth. And it's from this process. The screening part, we have a clinic already set up to follow these. We've already talked to the radiologist to put language in the reports to make it very easy to know where to send these patients and what to do. So this stuff is ready, and if you decide not to use this process, we can help your clinics or help you if you want the help to kind of figure out how to do this, and then work with us to get your patient the best care they can. You want to do this and follow the patient in your clinic, I think it's awesome. Let us know, and if we can help you in any way, be more than happy to do that. But I think that's what's going to take, and I think we've got all of the materials here at ECU to really make a difference. And lung cancer screening is going to be the next one, and that's my mission, and Dr. Baldwin has charged me to get that done. So this is our group, and I've showed you this before, and this is right now has been really the highlight of my career to work with these folks. And I really think that we've got outstanding folks here. And not only in lung cancer, thoracic malignancies, but also in all of our programs. You should be very proud of training here and going to school here, and I think working here. And we've got the opportunity to really make a huge difference to Eastern North Carolina. And I don't think it stops there. I want to take over the state. I just don't want to stop here. But this is our folks. Please feel free to call us. You can call me on my cell phone anytime. Text me, call me. If I'm in town, I will see your patient. I don't have to be on service. I will make time to see your patient. I will make sure that your patient gets the appropriate treatment and keep you in the loop. Call me directly. Call me, text me, whatever you want to do. Just, you don't have to, lung nodes or lung mass, not sure, call me. You guys know me, I'm pretty calm. I'm not going to bite your head off. I might tease you a little bit when you're around with me. Not that bad. And then Teresa Parent right here is actually going to be the new thoracic oncology coordinator for the hospital. The hospital has finally recognized this as well, and this is going to be an organized approach with all inviting hospitals to work on this thoracic malignancy. Sorry I cut off her number there, but it's 744-1789. And that'll get you directly into our thoracic oncology program, and we can present these patients at our conference and clinic on Thursdays. It's a one-stop shop. I like to say it's a Walmart of lung cancer. You get your tires and your mayonnaise at the same place. Thanks for listening to me. I appreciate it.
Mark, is it better to, if you want to screen a patient, just to send them to your clinic, or is it better to do your own CT? And the reason why I'm asking it has to do with three things. It's cost, it's radiation exposure, and it's obviously, as you said, the expertise of the individual reading it. So, if I want to start doing this, give me your thoughts.
Well, I think if you want to start doing it, this is going to sound a little bit elementary, but I think you just got to have a plan of what you're going to do and how you're going to handle all the stuff, which is fine. I mean, so you follow the guidelines of whichever one you pick up there. You get the high-risk patients, you have a relationship wherever you want to get the CT scan done and understand who's reading. And then you've got to have a method of making sure you're following those patients. I think you also, in my opinion, probably is going to be part of the insurance thing, I'm sure, is going to be smoking cessation, those kind of things associated with it. So I think it's really going to be a process. So if you want to do it, I think you go and you read the U.S. Community Task Force. That's a very good document, and you decide what you're going to do and you set it up, and you're just ready to follow. I think internal medicine office or family practice office could easily do this.
Well, years ago, we used to do silent CTs for sinusitis all the time. We finally got a radiologist here in town to create a unified approach to that. Right? And that's where I'm headed with this. Do we need to come up with a unified, lower cost, lower radiation approach to this, where people know this is where I go?
So we're a little bit fortunate here. Yes, I think in general, all comers, yes. We're fortunate. From the same people who read all the CTs. And I've already talked to them, and we've talked about those CT screening, exactly what okay, legal on board with this. And also, particularly, what kind of language you put into the report. So, we're setting up a system. Twofold. Patient comes to the emergency department. I'm going to be a little bit simple here. Had gout, so the short break. And a CTD profile. Need to follow up with you. So what is our responsibility to make sure that person is followed? One thing we want to do is try to set up a system to where we try to identify patients who don't have vision. And number two, give them an opportunity to follow up with somebody. And then number three, we can have a fail-safe with our SPIN clinical. How are we going to do that? You could hire someone that's not even necessarily medical, but can read a report. You can read a report and the radiologist put in there 1 centimeter pulmonary nodule speculated, highly suspicious for malignancy, recommend biopsy. That clear, recommend biopsy. That gets referred for non-assigned patients to our thoracic oncology. 7 millimeter nodule, indeterminate, recommend CT scan in 3 months. Person sees that gets referred to our SPIN. Contact the patient and say, hey, look, we have a doctor, maybe not a doctor. Look, we'd love to have you come follow up with us, or we can try to find a doctor. So you kind of kill the two birds with one stone. You're helping patients get physicians, primary care physicians, and you're also making sure there's not. Same process needs to happen within your own system. So the language is going to be that easy. And I don't know if you guys have noticed on reports, they're starting to do that. They'll say recommend bronchoscopy, or recommend this, or recommend follow-up in 3 to 6 months. That's fine. So the language can be made very easy.
Well, I think as it matures and you build this program on the back end, I think that needs to be brought in through the chief of staff report or something. But then on the front end is if we go there with the recommendations of the task force, then that needs to be built at the applicant. I'm hogging the questions, but I'll touch one more. I'm confused. The study that you started out with said they had to be within 15 years of stopping smoking.
You have to read the task force.
Well, there's two. There was, to get into that study, you had to be within. And then
Right.
the task force, once you got 15 years out, you could stop.
Yeah.
And I'm confused about that. Obviously, I could argue somebody saying, well, if you're smoking, why do I need to do preventive care? I mean, that's a terrible thing to say. We don't see that. Why did they, it's almost like, I mean, I think you need to be screening people that are still smoking.
Yeah. Oh, yeah. And I think what they're saying is you stop screening 15 years after you stop smoking, right? So if you were smoking 15 years ago, you can get a screen, but after that, you won't need more.
But the data they used to make that recommendation, you had to stop smoking.
For 15 years.
What was the logic behind that?
I think it's a misinterpretation. If you were still smoking, you would have studied. If you had stopped smoking, you had to have stopped
Within
the last
15 years.
Yeah, I'm not sure. Thank you.
Yeah, within 15
Okay.
years.
Good.
Yes.
So Mark, you mentioned in the National Lung Cancer Study that they also track quality of life. And so for many of us, it's not if we live or die, but if the quality of life remains great. You didn't mention those outcomes. Can you talk a little bit about that?
Yeah, so the quality of life, I think, particularly with that, is that most of the folks, and I'm trying to remember the exact data, but again, they use the PLCO data, but most of it looked like it was going to be a decent quality of life. I'm trying to remember exactly what the ratios were on that. But the folks who went through the surgery, the complication rate for the nodules was so low that they felt that the benefits of doing the screening outweighed the risk, and it didn't adversely affect most people. A lot of this stuff, I think, is still, when you read the paper, they're kind of vague. I think they're still gathering information. There's been so much data that's come off the lung cancer screening trial and PLCO that I don't think we've quite answered all those questions. I'm still a little bit skeptical because I think things like this, we're still not 100% sure. But I think there's enough smoke there to try. And I mean, it's easy to say, but I think there's.
We have to find the right patient population
That's
to
the
make
key.
the greatest
Yeah, and
impact.
I think they've got it. I think the age is about right. I mean, and this is my mistake. I've got to be very careful when I say this. It's my mistake. Look, there's arguments out there. If I had Dr. Walker here right now, he'd be standing up saying 55 is too old. Why are we screening at 55 when you breast cancer and other things? So when the U.S. Preventive Task Force came out with this, they did it like in August. No, so they did it in the spring, I think, and then they made their announcement preliminary, and then they left a few months for public response before they came out with the final at the end of August, September. And reading some of those responses was some people very much like what you said.
Thank you.
Thank you, Mark.